non-pharmacological approaches, e-health. I just moved this by pressing this button. My work is mostly in technology and health, but I can't even operate a simple clicker. And that actually is a big advantage because I'm not in any way, captured by the technology. It is simply a method. For the delivery of care by electronic means, by a phone, we've had phones for 100 years, tablet, computer, video conference, any number of different ways. Mobile phones are now very popular, and that's another way of doing it. You can have, with e-health, either no human contact, and it's be completely taken over by the technology, such as in an app. You can have some contact where there's an integration of contact with a human being, or you can have full contact where you get the same amount of contact, but the e-health is just used to scaffold onto the treatment. The other issue with e-health is that because e-health can take over some of the effects, you can have some people who usually treat doctors, psychologists, or you can begin to expand the role of other professionals, such as a physiotherapy assistant, or you can actually go to somebody who doesn't have a professional designation, and certainly a paraprofessional. And finally, of course, you can start to use other patients as supporters and the human contact in the intervention. There's dozens, as Gord said, there's dozens of randomized trials in cognitive behavior therapy, and there's dozens of randomized trials in e-health, various ones. I won't go through them all. There's lots of systematic reviews. I was involved and did one of the first e-health interventions for pain, and this book, which is the cover of the book, is Help Yourself, is the program that we called it. We published that the first trial in 1989, way back in the last century, so it's been around even on an e-health basis. In that case, we used a handbook and a telephone. We did 5 trials, all were effective. We published the papers. I traveled around the world and dined out on my success, because then it was really quite novel. Then when I came home, and you look at whether or not this strategy, which was shown to be effective, was used, and the answer was no. I looked up recently our booklet on Amazon, and it is actually on the bestseller list, but it's in the 4,583,000th position. So that means that there are over 4.5 million books that sell better than mine do. The story of my life has been one of repeated failures, but we've been very. This is one of my most profound. So the implementation of e-health has been a major impediment to its use in any sort of chronic pain. So the advantages of e-health, how many people here bank electronically? Could you raise your hands? How many people here don't bank electronically ever? Oh, yes, good. You put it in your sock, do you? And then carry it to But what about your flights here, those of you who came from out of town? What percentage of you booked your flight with all the frustration that it may be in standing in line? Most of you booked your flights electronically? You can do grocery shopping electronically. I don't advise it. I like to pinch the tomatoes. And you can do, if you have stocks, these are financial, situations. They're highly sensitive. You don't want somebody to steal your stocks or make trades. You can do that. You can do anything like that, instantly. It's commonplace. It's the way people do it. But not in healthcare. You can, some places, really progressive places, you can actually book appointments online. Some places, really progressive places, you get reminders online. Well, for 15 years, the public library has been telling me my books are overdue using electronic reminders, but we haven't, even electronic reminders, the simplest e-health, haven't been done in healthcare. So we're really far behind. Some of the advantages of e-health is it can reduce or eliminate incidental costs, for instance, time off work and travel costs. We think that healthcare in Canada is free, but it's not. If I have to take my child, or if I have to myself go for 10 sessions for cognitive behavior therapy, I could, take time off work, travel, pay for parking. You know how much it costs to park in a hospital parking lot? And maybe have a babysitter for another child? Eat out? It can cost you thousands of dollars for a course of free treatment. The other advantage of e-health is it can increase the number of cases treated if you substitute or reduce who's taking care of them. So for instance, in a program that I've developed in mental health, we use coaches, paraprofessionals, and they do all of the treatment. So you don't have to have a psychologist. I can train a paraprofessional in about 4 weeks to be able to start treating. They're supervised, they have supports around them, they have really good care. You can standardize delivery of care. As one of our speakers this morning said, well, you get 6 different or one of the audience said, I got 6 different suggestions for different things. You can measure outcomes. You can measure, imagine that. When I tell people outside of healthcare that we don't know what our outcomes are, they don't believe me. I say, well, yeah, we know who dies, we know who gets a major infection, but we don't know anything else. And you can use analytics to see, big data analytics to see what seems to work. There's 2, we heard that Mick and Gordon were putting aside some different views, and really they're talking about 2 different approaches to pain management in using psychological methods. But they don't have to be completely different, they're complementary. Mick was emphasizing behavioral return to work, focusing on increasing activity, moving in that direction. And Mick may correct me, but Mick, you should know, is also the inventor of the catastrophizing scale, so he knows all about the cognitive stuff. Gordon, on the other hand, was emphasizing, although in his work he also looks at behavioral efforts, he was emphasizing the cognitive issues. And again, I think those are 2, it's a balance with those. The stress management is sometimes termed cognitive issues. You teach relaxation or breathing or cognitive coping skills, you reduce catastrophizing, whereas more of a reduction of avoidance is reducing avoidance, and you may use coping skills to facilitate that. There is emerging, in my view, a better evidence for the avoidance model where you do use cognitive and behavioral systems to help a little bit. So here's 2 slides from a group from the Karolinska Institute, and you see on the ladder, which is an exposure ladder. So the highest level is what they're trying to get the commitment to go to. Go to school even when I have a lot of pain, and works up to that. On the other side, you see a very brief mindfulness intervention, and to try and control, stop, observe, and then go ahead and do it. We can use e-health to increase patient and family-centered care, to increase effectiveness with standardization and outcome monitoring, increase efficiency by using self-management and paraprofessionals, and increase access by reducing wait lists and incidental costs. So more science is needed, but the major problem is implementation. As Nike says, just do it. Thank you.